3, 2, 1. Please start, sir.
Good evening, friends. Welcome to the 43rd edition of the PG Track program, which we have been running successfully for almost a year. So there was a lot of demand from the residents, mails, and messages that we wanted sessions on imaging because cardiac imaging is an integral part of our cardiac training. And many times, due to lack of the facilities or probably lack of the interest or often lack of the proper teaching and approach, we are not able to understand the basics and the use and application of the advanced cardiac imaging modalities in cardiovascular diseases. So hence today's session and the next two sessions that we thought that we should have the role and the understanding of the principles of the cardiac magnetic resonance imaging, of the CT angiography and the perfusion imaging techniques in various disease and various disorders, related to heart. So we have the pleasure of having Dr. Johann Christopher, who has joined us from South. He's Director of Cardiac Imaging in the Care Group of Hospitals. My colleagues, Professor Sumod Kurian and Professor Girish MP, are here with us to facilitate this session. So I would request, without wasting any time, Dr. Sumod to please invite Dr. Johann. He is one of the finest speakers on cardiac imaging, and he has prepared a very practical and a good approach. We had discussed this particular thing. And if you have any questions, any comments, or any clarifications that are required, my request to you is please mail it to us, please write to us, because that is the way we can address your particular concerns. But we have tried to customize these sessions from both points, not only from your exam points, from what you should know, but also what is important for your clinical and practical cardiology training. So over to you, Dr. Sumod, to start the session.
Yeah, we all know that cardiac imaging, especially MRI, had really revolutionized the understanding, especially the three-dimensional understanding in pediatric cardiology, and also in cardiomyopathies and every even in ischemic heart disease, it has really helped us in evaluating the patients. But as Dr. Mohit has clearly told that in most settings, a good infrastructure of cardiac imaging is not available, and many of us are not so familiar with these images. So it is a good opportunity for us all to learn and understand. And we welcome Dr. Johann Christopher from Care Hospital. He is the Director of Cardiac Imaging there. Welcome, Dr. Johann. Please come and explain to us the various aspects of cardiac MRI.
Dr. Sumod, thank you for the faculty of GB Pant. I incidentally passed out. I did my final exam at GB Pant many years ago, a national board exam. So there's a lot of nostalgia there. And those days, very few people were passing. So I was very lucky. So it's my pleasure to bring you the first part of the 3 series on cardiac MR, cardiac CT, and nuclear cardiology. So I'm going to go slow, explain some of the concepts. And more than the cardiac image itself, it's important to integrate these things with the story, the exam, and the other modalities that we're already familiar with. So I will just take you through that. And you can use the chat box if you have access to it to send your questions, or we can address it in the next meeting, which we're going to have possibly next week. So today will be predominantly on cardiac MR. To put things in perspective, I'm going to show you a couple of questions. You can have a look at it, take a screenshot, analyze it, and then we will look at the answers once I'm done. So the first question is, what is the role of MR in CHF? And the answers are as follows: morphology, function, characterization, risk stratification, or all of the above. The second question is, viable myocardium is defined as a scar greater than 50% of the myocardium, less than 25%, less than 50, or none of the above. What is the role of delayed enhancement on MRI? Is it to look at increased clinical events? Does it portend increased risk of arrhythmias? Does it look at evaluation of etiology, or all of the above? What is the scar pattern in sarcoidosis? Is it subendocardial? Is it epicardial, mid-myocardial, or all of the above? What is the condition with a low T1 value? Is it Fabry's disease? Is it amyloid, hypertrophic cardiomyopathy, or all of the above? And number 6 is, what is the condition with a high ECV value? Six questions. I hope you've had a chance to make a note of it. We'll come back to these questions once I'm done in the last 10 to 12 minutes. In 2008, I had the pleasure of coming back to India from the US. So we got our first dual source CT, which is below, and also our 1.5 Tesla MR with a specific cardiac package. It was almost the same year that this very interesting editorial came up in the Times of India, where chronic diseases were to bleed India. India would face a huge burden. This was way back 2008, and we could see what's happening today. We do realize that India will be paying a heavy cost along with the other developing countries. And asymptomatic patients are what the main focus of cardiac imaging are, because you've got many tools to look at symptomatic patients. It's also important in coronary artery disease when you do imaging to have a specific goal. And the goal is to increase the event-free survival, to improve the LV functional capacity, and to have relief from anginal symptoms. So based on these three goals, we
Johann, if you can switch off your video. The voice is not coming.
There's a nuclear lab, which is connected. There's a cardiac MR, which I'm going to talk about. It's cardiac CT. Remember, we're not calling it coronary CT. It's cardiac CT because we look at other structures, and also the echo lab. And finally, leads to the invasive cath lab. So it's important to have all these little points connected. So that
Johann, I would like to interrupt. Just if you can switch off your video because it is interrupting in between. Am I right, Mudit?
Shall I stop the video?
Yeah, video you
yes,
stop.
Sir.
Yours to be, then
if you can, sir can stop the video.
Yeah, please go ahead now.
So this is, yeah. So all these points are important to get a wholesome value for the patient, and we'll be looking at a couple of cases a little later. Now, why are we very gung-ho about the MR? We know that there are four essential facets of cardiac disease. One is the morphology, second is function, third is tissue, and the fourth is metabolism. Now, if you look at echo, it has a lot of predominant on the morphology and function, but hardly anything on the tissue and metabolism. Nuclear imaging is very good with function and metabolism, and CT is very good with morphology and function. But MR is a tool that looks at all the facets in a very equanimous manner. So there is morphology, there is function, there is tissue characterization, and also there is a metabolism. Now, among the top 5 indications in CMR, the first indication, obviously, because we have a load of disease, is advanced ischemia detection. So we look at wall motion, we look at ischemia either via dobutamine or adenosine, and we look at scar tissue visualization. The second important disease that we look at in MR, and this is something that is very unique, is the ability to isolate, evaluate, and also look at the prognosis of the non-ischemic cardiomyopathies, which incidentally we are seeing more of as the days go by, and also a very specific cardiomyopathy, which is myocarditis, and all of you have been seeing a lot of it in the pandemic, which happened over the last 1 year. The third major indication is obviously in electrophysiology, and we have a very busy electrophysiology center. So, and we do a lot of AF and ventricular VT ablations. So MR is very, very key in the pre and post evaluation of such patients. We also do a little bit of MRI in patients with, for going ahead with CRT, because it gives us some very important clues about the success and failure of CRT, apart from the other electrophysiological clues. It is a very good standalone technique for cardiac function, especially in those diseases where ejection fraction is paramount in making decisions. And lastly, as Dr. Sumodh is here, it's a very, very vital tool in the evaluation of congenital heart disease. And it has become almost a standalone technique in that field. Now, just a little snapshot on the technique. There's little or no preparation for a cardiac MR. Patients are not fasting. They usually come with a light breakfast first thing in the morning. Male patients, the chest hair has to be removed, and you need to have a creatinine level. We generally do not do cardiac MR if the GFR is less than 40 because of the serious risk of NSF. For those of you who are new to that, it's nephrogenic systemic fibrosis. We've seen a couple of cases in the US, but in India, I've just seen one or two. It's a very deathly sort of disease which resembles systemic sclerosis. And it happens when the GFR goes below 30. So apart from that, really no preparation. We like to prepare our patients one day before by telling them about breath holding. Here, you don't need to take a deep breath. It's just holding the breath for the various sequences. There are about 30 to 35 sequences in a typical MR data set. So good breath holding really gives us good quality pictures. The positioning is important. We use special non-ferrous ECG leads. That's very specific to the MR. The ECG signal is very important because the whole basis of getting good pictures is from the systolic and diastolic components. Breath hold again is essential, but with the newer MR sequences, we can do without it by doing what is called the diaphragmatic navigator sequences, which use the diaphragmatic movement to time it. However, good breath hold helps in getting those pictures better and also faster. The basic sequences are of only really three. We do the CINI sequences, T1 and T2 maps, and the inversion recovery. This is for after you give the gadolinium. We use a special extracellular contrast called gadolinium. The dose is about 0.1 millimole per kg, works out to about 14 cc's for a 70 kilo person. And this is the typical workflow in the MR suite. I will just start here from the operator console. He gives the sequence which is required to the pulse sequence controller, and that has access to the RF transmitter, the gradient coil amplifier, which is inset in the MR. And what this does is creates a new magnetic field. We know that the magnet never really stops, so there is an intrinsic magnetic field already there. The RF transmitter then changes the homogeneity so that we get these signals. Now, the signals that come are from the special coil that we use. We have different coils for different parts. And this signal, analog signal, comes to this receiver and then gets converged to a image reconstruction unit, which is inbuilt in the system, which then transfers the raw data into the imaging database. And that's when imagers like us look at it, and we are able to, from the raw data, able to see the sequences and the images. So it's very important here that you have to have a good tech. You got to train your tech. And many times, even today, I sit with my tech, especially when we're looking at difficult patients. Difficult patients means not the run-of-the-mill viability patients, but patients with congenital heart disease, patients with amyloidosis, for example, and I will tell you some of those challenges as we go along. So just looking at heart failure as an important disease entity, because this is an area wherein a lot of the mainstream cardiologists sort of like to move it away from their platter, because sometimes there is not much you can offer in terms of intervention, although this has been changing over the last 4 to 5 years. So the main role of imaging here is to get that EF right, because we know all the data is more or less divided between reduced ejection fraction, HFrEF, and HFpEF. So the MR gives very good quantification. We know the survival also changes drastically depending on the ejection fraction. We also know that there is multiple imaging modalities like the stress maybe, the MUGA, contrast, LV angiograms. Most of us don't do it anymore. Echocardiograms, we have 3D good quality echoes now. And finally, the MR. Suffice to say that the MUGA has been more or less relegated because of the radiation dose. Because of time and contrast, we don't do LV angiograms routinely. So it's basically between echo and MR, and stress maybe carries the load of radiation. So we don't routinely use it for ejection fraction. Now, this is the data set, and hope you can actually see the videos down below. It's a stack of 8. This is the standard stack that we take from base to apex. And this clearly sort of gives you an idea as to how good the volumetric and the ejection fraction analysis of MRI is over and above the standard techniques like echo that we use. And remember, this is windowless and is not operator specific. So despite the patient being obese, having COPD, not a great operator, you get these really high quality images with good spatial resolution. The data set is above, you get the ejection fraction, you get the mass, end diastolic, end systolic volumes, the stroke volume, and the cardiac output. So this is possibly one of the most important and the basic steps when we start the MRI, and this good quality data helps us sort of move onwards. In terms of appropriateness, you will also understand by the American College and the Society of Cardiac MR that MRI is useful both in the severely reduced, the moderately reduced, and the mild LV dysfunction compared to the other competing techniques. The second issue in heart failure is the presence or absence of coronary artery disease. And we have been traditionally taught based on Felker's data many years ago that ischemic patients generally have a lower survival. And we have been looking at it by doing angiograms like the one on the left is normal. And here you have a patient with a total occlusion of the LAD. But however, over time, the MR has been a very good tool in looking at these patients and assessing whether coronary artery disease is there or not, or rather if coronary artery disease is playing a role in these patients. And if you look at the box A on the top left corner of your screen, you will see the gray, which is the black is the myocardium and the gray is the cavity and the white is the scar. Note here the white on the anterolateral and the infralateral aspect is attached to the subendocardium, and it just short of the epicardium, and so also is the one on the anterolateral segment. It's literally hugging the cavity, so that means it's subendocardial. And because of the wavefront hypothesis that we all know, this is very classical of a scar secondary to a coronary artery disease. If you look at B, you will see that the scar in white is completely interposed or sandwiched between two black layers, which basically means it's mid-myocardial and therefore does not have a coronary or a vascular basis. The scar is because of a myocardial or a muscle pathology, and this typically happens in a dilated cardiomyopathy with scarring. Moving on to C, this is a classic example of a patient with a hypertrophied septum, hypertrophic cardiomyopathy, and these islands of white are the patchy non-vascular scars in hypertrophic cardiomyopathy, and the evaluation of these scars helps us in the risk stratification. D, again, you can see there is a sandwich of black between the white, and here again it is more in the infralateral aspect, very, very suggestive of myocarditis. And E, again, you will find that there is a septal scar, there is a scar at the anterior RV-LV junction and also at the infralateral wall. And again, you can see that the subendocardial layer is free. And this is again suggestive of a non-vascular pathology. In this case, it would be generally sarcoid or tuberculosis. And when we look at F, this is something that many of you would be familiar. You can see this bullseye appearance is the typical bullseye appearance of the scar, which is completely involving all the territories. It's a global subendocardial distribution. And this is the only non-ischemic cardiomyopathy which has a subendocardial origin to the scar. And this is classically amyloidosis. And how we distinguish it is it crosses vascular territories and it's not in a particular vascular territory, although it is subendocardial. So this is a very important slide And I hope you have sort of looked at it in detail, because just appreciation of this will give you a very, very major clue as to the etiology. Now, if you look at the American College Practice Guidelines, non-invasive imaging has had a 2B level of evidence C, which is not too bad, in that for the further evaluation of heart failure, the cardiac MR is a very, very good tool. It has not got a 1B or 1A simply because we don't have enough data and there are not enough scanners to give you that data. Now, this is generally what a cardiac MR can do in a good center with good and well-trained people. Most aspects of cardiac disease, whether congenital, vascular, or non-vascular, can be sort of evaluated and prognosticated with the cardiac MR. We'll first look at coronary artery disease, because that is the most common disease that most of us are facing and you will also face in the future. The first thing, as I told you, is the acquisition of a good quality data set, a stack of 8 short axis images, and that's what you're seeing on the screen. And we follow the 17 segment American ASE model. You will know that the American Society of Echo and the Society of Cardiac MRI work together in more than one instance. And they, many of the times, they publish joint statements. So we start with the basal, mid, distal, and finally the apex, which is here. So the same American Society guidelines apply here in MR, and that's what you're going to see. The second data set that you're now viewing is, once you've got that data set, we give gadolinium about 10 to 14 cc depending on the weight of the patient. And as the gadolinium is being injected by an injector, there's a motorized injector which is MR compatible. We look at what is called the first pass of the gadolinium through the heart. And this is what you're seeing as it comes through to the RA, the RV, the left atrium, and then finally through the left ventricular cavity. And what we are seeing here is that areas of black in the anterior septum, if you pay attention here, you can see these dark areas, and these dark areas correspond to decreased perfusion in the anterior septum, which is analogous to having ischemia in the LAD territory. Now, the same gadolinium is re-injected a little while later after the infusion of 3 minutes of adenosine through a special MR compatible pump. And then we compare the rest and stress perfusion and look for any mismatch between the stress and rest perfusion, similar to what you would be doing on the nuclear scans, which I will be hopefully sharing with you next week. Once this is done, we wait for 8 to 10 minutes based on the myocardial nulling, and this is something that requires a little bit of practice and expertise. And then we re-image these patients with a sequence called PSIR, which is basically a 10-minute post-gadolinium sequence, and we look for hyper-enhancement or white enhancement in the wall of the myocardium. You can again see the same stack of 8 images that you saw in cine, that you saw in perfusion, and now you're seeing it in delayed, and you can see the white here. I'm trying to point to it. And you can also see the healthy black area. So in MR, white is dead tissue and black is live tissue in whatever disease entity you see. So the presence of white basically means death or disease, and we call it technically hyper-enhancement. What is also very important, if I can come back, is that when we look at the hyper-enhancement, it is not a pretty picture that we are seeing, but we are also grading normal, which is completely black. We are grading less than 25%, as in this case. We're looking at 25 to 50%, as in this place. And we're looking at more than 50% distally towards the apex, and this is what we call transmural. So this is very important and also has a link to the question that I've given you before. And when we look at all the three data sets, that is, we look at the wall motion, we look at the perfusion and the hyperenhancement, that is when we make an assessment on the viability. And you can clearly see here that the light green, which is hypokinetic, also has a less than 25 or 25 to 50% scar, and that is also viable. And the areas which have a more than 50% scar in dark blue are non-viable in pink here. So any scar tissue which is more than 50% of the wall thickness is termed as non-viable. Now, the other aspects of coronary artery disease can be seen here. And this is a nice example of a patient with a LAD scar with a left ventricular apical aneurysm with a large thrombus sitting there in the apex. And this is the delayed enhancement post-gadolinium showing you the transmural nature of the scar, and also the dark area is the thrombus which is there. So some of the complications of MI can also be seen on the MR. And this is a very interesting patient who was successfully stented in the LAD and developed pain 2 days later. We took him up for an MR, and when we did the cine and the perfusion, this is what we saw. This is a perforation, a myocardial perforation with a rapidly increasing pericardial effusion, and this patient was taken up for urgent surgery and a pericardial patch was applied. So MR is a very good tool to assess some of the complications of coronary artery disease as well. Now, just to help you understand, I've taken some real life pictures to show you that this is a patient with an anterior wall MI. The white here is the scar. And remember, this is subendocardial. This is less than 50%, except towards the apex, which it becomes transmural. So generally, this is a patient who will do quite well once you revascularize him, because his scar is less than 50%. This is an example of another patient with the same anterior wall MI, but here the scar extends right from the base to the apex, and it covers more than 50% of the myocardium. And these areas of black that you see are not healthy myocardium, they're pockets of them, but they are areas of microvascular obstruction, which is another important entity that you can see on MR. And this is a patient who's not going to recover post-revasc, whether you do stenting or bypass. And he's a patient who's well left on optimal medical management. And when he crosses the 40th day, and if you're able to evaluate him again, his ejection fraction is low, he would be a very strong candidate for an intracardiac defibrillator because of the large scar burden. Anything nearing 50%, the chance of sudden cardiac death is extremely high, more than 30% per year. Moving on, this is a classic example of a patient with a left circumflex occlusion, and you can see the posterolateral wall has a transmural scar completely encompassing the thinned out wall, and this patient again has a non-viable myocardium in the circ territory. Another patient with a similar completely encompassing the entire wall, and this patient has a transmural scar in the circ territory, and that is non-viable. There's another patient who came with heart failure, but he has only a subendocardial scar. He has a totally occluded left circumflex, but this patient will do well post-revascularization.
Johann, your voice is not there. Mudit, are you there?
Yes, sir. I will connect.
For ejection fraction.
Yeah, Johann, if you could go
Yes.
back, your voice had was lost for almost 15 seconds. So you could re-describe the last slide. Yeah, right.
Yeah. So this is a patient with an LCX scar. This patient had a total occlusion of the LCX, but observe here that the scar or gadolinium enhancement is only less than 50% of the thickness of the myocardium. Henceforth, this patient will actually do well once you open the L6. This is a patient with an RCA total occlusion, and this is a two-chamber view clearly showing an entire width thickness of gadolinium. And again, this is a transmural scar occupying more than 50%, and this patient is not going to do well post-revasc. So, encapsulating what I told you about coronary artery disease, ejection fraction evaluation, volumetric evaluation, a scar analysis is all the important components, and obviously ischemia using either adenosine or dobutamine are the four major components that MRI looks at in coronary artery disease, and this helps us fine-tune our therapy when we sort of manage these patients. Moving on to valvular heart disease, just want to tell you that the American Society of Echo and the SCMR work together, and they publish guidelines generally together, and this has been happening from 2017. Now, aortic valve assessment, as you know, can be tricky on echo, especially in heavily calcified valves. Calcification does not pose any problem for us, so planimetry of a very finely sliced aortic valve is possible on the MR, and you get very, very concordant measurements, especially in a heavily calcified deformed valve where the Doppler is not very good, the flow is not very good, and it's very difficult even on T to do the planimetry, as you can see in this patient. So you get very good pictures on MR, and we do it usually as a second umpire in patients with aortic stenosis. What is also important in the era of TAVR is that a patient who has renal failure and you're not able to do a CT for any reason, we can get similar information from the MR without having to use gadolinium by doing something called TOF images, where we can actually assess the valve as I've shown you, and also look at the aortic root and the proximal and descending thoracic aorta on MRI, and serves as a very good secondary supplement to CT wherever it is not possible. MR really shines in valvular regurgitations because it is a king in terms of volumetry for the LV, and also to assess what is the blood flow going out of the aorta. For this, we use what is called the phase contrast imaging or VEC imaging, and this is an example where we are able to catalog and quantify the blood flow above the aortic valve. And we also are able to quantify, based on the magnetic homogenization, the blood flowing down. And this is the kind of graph that we get on the software, that the patient has a forward flow of 147.6 ml, but it also has a regurgitant volume of 70 ml in diastole, and therefore the regurgitant fraction is 48%. And we know from echo that anything more than 45% is basically severe aortic regurgitation. And this is the cine of the same patient. You can see a deformed aortic valve. There's a mild stenosis, but there is a torrential aortic regurgitation here. And then when we calculated the flow across aortic valve, this is what we got. So in the assessment of patients with regurgitation, especially when we are looking at the timing of surgery, because this does not involve gadolinium, which is expensive, sequential MR evaluation, possibly every 6 months in a patient to moderate to severe regurgitation, will give us the best timing when to intervene in these patients, and also act as a second umpire when there is some doubt in the echocardiogram. The third area is mitral stenosis, and we know that echo is king, and with 3D echo, we really have no problems. But we have our own data and some data from outside, wherein challenging patients with the very deformed mitral valves, or when you have a difficult decision where the echo and the clinical parameters are not concordant, MR can step in, and we have done our own study with one of our own students and looked at echo versus MR, and we found that the MRI values are very concordant with that of transthoracic echo. However, it is only a third empire in this situation for those difficult valves. As I mentioned earlier, regurgitation MR is king. It's possibly the gold standard in the evaluation because we don't worry about the eccentricity of the regurgitation jet. We don't have to worry about aligning our Doppler, which can be challenging in some patients with window issues. Here, the only thing we look at is we do the cine, and here you can see the patient with an extensive eccentric mitral regurgitation with a dilated LA. We do a good LA evaluation. We get the LAVI, the left ventricle volumetry, any other valve issue. We give the gadolinium, and we can see that there is also scarring in that area, suggesting the etiology of mitral regurgitation. And then what we do is we put things together in that because of the excellent volumetry of the MR, we are able to get the end diastolic volume, and then we get the end systolic volume. And what we do is we look at the flow across the aortic valve. And that is something I have just showed you. I'll just go back to that again. We look at the flow across the aortic valve. So what we do is we subtract the stroke volume from the aortic flow. And if you look at the law of conservation of mass, what it means is that whatever left the LV should go into the aorta. And if there is a deficit in the aortic flow, it means the rest of the blood has gone into the mitral regurgitation. So the stroke volume of the LV minus the volume of blood flowing through the aorta gives us a very, very reproducible mitral regurgitation volume, as well as a mitral regurgitation fraction, which is extremely accurate, again, when you're sequentially following these patients. And as you know, that MR has no radiation and no windowing problems, and it has no very minimal operator sort of dependence. So it becomes a very gold standard to watch these patients over time before you make the decision to do surgical mitral valve replacement. Moving on from valvular heart disease to pericardial disease. This is an interesting picture, and most of you will understand that it belongs to a patient who has a constrictive physiology. As you can see, the sailboat appearance of the septum flapping widely with a marked constraint of the lateral walls. We call them laterally challenged ventricles. And this is a classic example of ventricular interdependence. And what is the additional role for MR is that although it shows the physiology very well, I'm sure this can be also acquired with good quality 2D. But in addition, after gadolinium, it gives us important information. And this is the same patient, and you can clearly see the white around the heart, which is in the pericardium. There is gadolinium deposition. And what that tells us here is that it's not scarring. It is pericardial inflammation. So in these patients, the pericardium is very vascular, it's inflamed, and even though these patients have a significant constrictive physiology, they are not patients that you want to send to the theater for pericardial stripping because they will bleed. These are patients left on optimal medical therapy, especially steroids. And we have a fairly good collection of patients where we have demonstrated gadolinium enhancement on the MRI, who have done almost extremely well and never required surgery just with 4 to 8 weeks of steroid. So not only demonstrating the pathology here or the pathophysiology of constriction, but also giving you a little clue about the possibility of surgery, the etiology, and in some patients, if you find the classical nodes which are there in the mediastinum, again gives you a pointer that it is possibly infective etiology, maybe tuberculosis. And then we do a mediastinoscopy or mediastinal biopsies, and then we get it. And many times these patients have a non-caseating granuloma, and they do very well with steroid. So functional evaluation and also the characterization. Now, for the adult population, or GUCH as we call them, traditionally our lab does what is called the post-ICR assessment. And this is a very important assessment that we make of children who have had the TOF surgeries in the past and come back with failure. Many of them have either no or very poor valves. So the RV volumetry and the pulmonary regurgitation is assessed very beautifully using the cine images and the flow assessments, and we get a very good graph of the forward volume across the pulmonary valve, the regurgitant volume across the pulmonary valve, and we get the regurgitant fraction in this patient was 37%, which is significant for this patient. And this helps in planning the next step. Cardiac MR is also good for assessing extra cardiac structures. And one of the important areas that we look at is the coarctation of aorta, which can be sometimes challenging on echo due to window issues, and also because of aligning the Doppler along the stenosis. So in cardiac MR, we not only look at the stenosis severity and the location, but we also do a flow analysis at the diaphragm level and at a point 1 centimeter below the actual lesion. And what we find is that in significant coarcts, that the flow below at the level of diaphragm is at least 1.5 times the proximal location. And this is attributed to significant collaterals which join in after the lesion and feed the distal aorta. And so we know that irrespective of the stenosis, if we get a flow which is 1.5 times, we know that that coarctation is important, irrespective of what the flow data tells us. So these are some situations where the MR really helps us. Moving on to the real highlight of MR, and that's non-ischemic cardiomyopathies. And this is a nice slide showing you the entire length and breadth of the cardiomyopathies that are commonly seen and analyzed by us. And what is also important to know is that many of these cardiomyopathies have differing survival prognosis. As you can see, peripardium cardiomyopathy is very high up there with a good survival compared to the infiltrative diseases like amyloid and obviously HIV infection. So it is very important not only to make a diagnosis that this is a cardiomyopathy, but also tweak out the etiology because it seems to matter in terms of prognosis. What is very key is that by the application of gadolinium, you clearly are able to dissect out those patients with cardiomyopathy who have a benign prognosis in blue, who have no scar, and their all cause, the blue is the ones with the scar, and you can see that their event rates, whether it's all-cause mortality, heart failure, hospitalization, and sudden cardiac death, are extremely high by a factor of 3 to 4 compared to those patients with the same volumetry and ejection fractions who have no scar, and you can see how we're able to dissect out between these two groups. We also do understand that the non-ischemic cardiomyopathies are composed of a very heterogeneous group, and that is also the reason why HFpEF treatment modalities are not very good, because the underlying etiologies are so diverse and you require different stains in the path lab to really distinguish between Fabry's versus amyloid versus iron. But what we have is a very nice and unique technique which has come into the market about 5 years ago, and most of us are still getting to terms with it because it's an advanced mapping system seen only in the newest generations of MR, mostly in the 3T MRs, wherein we look at the native T1 values of the myocardium, and also we look at the extracellular volume, which is a parameter which is derived after you give gadolinium. So just to make it clear, the T1 values are acquired before gadolinium. These are intrinsic properties of the myocardial cell, and the ECV is a derived variant which is acquired post gadolinium. And the application of both are able to divide some of the cardiomyopathies into different groups. To again reiterate the point, the lowest native T1 values are seen in lipomatous metaplasia, typically in chronic infarcts with a lipid metaplasia, and also in fat-containing tumors like lipomas. The other disease entities which have a very low T1 value and a low ECV are Fabry's disease and iron deposition is slightly lower than the normal variant. I must stress over here that the T1 values are fairly dependent on the magnet in which it's done and the local population which has been mapped out by the magnet. So if you're asking for a T1 map, make sure your operator has done at least 100 T1s of normal subjects in his area and has a good local T1 map with him in order to make sense of the various diseases. The extracellular volume, however, is magnet independent and is a more objective parameter, although it requires the application of gadolinium. HCM, DCM are somewhere in between. Acute myocarditis has a higher T1, but the highest T1s come with an acute MI, followed by AL amyloidosis and ATR amyloidosis. And the ATR amyloidosis has a higher ECV content than the AL amyloidosis. And sometimes you're able to split these two entities based on that. So the highest T1s and ECVs are with the amyloidosis, and the highest T1 is with acute MI. So amyloidosis is on one part of the graph with a very high ECV and T1, and Fabry's disease is on the complete other end of the spectrum with a low T1 and ECV. So the pre-contrast T1 map, this does not involve the application of contrast, and this is important because it can be done in patients with CKD. It can be done cheaply because it requires just 10 minutes in the magnet and you can take out the patient for a good characterization. And we have been using this property extensively. We do the post-contrast T1 map after gadolinium, and then we create what is called an ECV map based on this calculation, including the hematocrit of the patient. Now, this is the data set that you can actually get on the MR. So you get a cine, you do the native T1 mapping, you give gadolinium, you look at the gadolinium enhancement as we've been seeing, then you recreate the ECV map based on the T1 pre and post, and then you have the first pass of gadolinium and you can look at the perfusion map. So cine, T1, delayed hyperenhancement, ECV and perfusion are all good parameters that we can get on the MR and very useful in these diseases. And this is a case of myocarditis presented as heart failure. And you can clearly see here the LV dysfunction, the regional wall, which is more global. And you can see the patchy scarring, the pericardial involvement, the pericardial effusion, suggesting that this is a myopericarditis pathology. And these patients will have a very similar presentation as an acute coronary event with chest pain, ECG changes. However, it is very important to distinguish them because the treatment is usually medical, especially with steroids. And this is where I was telling you that the T1 values are high. There is a patchy gadolinium late enhancement, typically in the infralateral wall. And the ECV, you can see, has expanded. It's much larger than a native ECV map. This is another patient who presented with heart failure, and you can see the beautiful 8-segment data set that we have, a modified 2-chamber view as you call, and this is something the DNB students will enjoy seeing. You can see here this meshwork of trabeculation in the left ventricle, and this is a case of non-compaction. Make sure you understand that here we use the criteria of more than 2.3:1 spongy to compact, and this is in diastole in comparison with echo, which is in systole 2:1. And the important thing here again is that there should be significant non-compaction in areas other than the apex to make that diagnosis. So you're not only making the diagnosis, but you're making it in a quantitative fashion. Moving on to inflammatory cardiomyopathies, and sarcoidosis is one such disease. This is a patient who had presented with worsening heart failure, LV dilatation, LA dilatation, LV dysfunction, regional wall not matching a coronary territory. And what is important is septal and lateral mid-myocardial starting without involving the subendocardium, which is classical for sarcoid. And what really adds icing to the cake is the presence of significant enhancing mediastinal nodes here, suggesting that it is of tuberculoid origin. What is also important is not only making the disease, but also when you get a significant amount of scarring, which we are able to now quantify, we are also seeing that the event-free survival drops quite drastically once you have a significant amount of gadolinium compared to the same patient with the same volumetry who does not have gadolinium deposition. We complement our MRI in these patients with a PET scan. And this is a patient who was diagnosed in 2015. Note the heavy FDG uptake. This is on a PET scanner, both on the mediastinal node and the myocardium. And this again showing you the AVID FDG assessment. We'll be talking more about it when we talk about the nuclear lectures. And with a good immunomodulatory treatment, including steroids and also methotrexate. In 2018, 3 years later, the map clearly shows that there is really no enhancement. This is the physiological thyroid uptake. And you can see the myocardium is dilated, dysfunction, but relatively free of FDG, suggesting that there has been good therapy for this patient. And this is our paper which we presented on the role of imaging PET and MRI in patients who were presenting with monomorphic ventricular tachycardia. Some of them are presenting for ICDs. They came as a referral to our e-period for ICDs, but almost 3/4 of them we managed medically with immunosuppressive therapy based on the MR and PET results. What is important today is we are moving into hybrid imaging. And this is a classical disease, if you ask me, where a PET MRI would be extremely useful. Looking at the scar on the MRI, the delayed enhancement, then looking at the inflammation on the PET scan, which is here, and then combining both into MR PET, the MR scores in terms of the scar and the PET scores in terms of the inflammation. And we know that sarcoid is a very good mix between inflammation and scar, and you get both of them in a single scan. Moving on to the classical restricted cardiomyopathy, most of you all will appreciate the biatrial dilatation, the small ventricles, the extremely hypertrophic septum. But these are all images that you get on echo. What we do offer you is a histopathological diagnosis. You can see the classic subendocardial global scarring. It's very difficult, I must say, to get these kind of images because myocardial nulling is very challenging in patients with amyloid. And in many small diagnostic centers where these patients are first set, we get absolutely normal scans because they don't know how to null them. T1 mapping has helped us. You can see the very high levels of T1 based on the color index. Yellow, you can see the subendocardial delayed enhancement on gadolinium. And then post-gadolinium, we look at the ECV. There's a marked increase in ECV in red. As you can see, there's a huge expansion of the myocardial space because of the amyloid deposition. And this is a nice case to show you the typical morphological appearance of amyloid, the interstitial deposition of amyloid, the T1 or ECV map of amyloid, which is high. And then after bortezomib therapy in this patient and steroid, we found that the ventricles have completed near to normal. There is hardly any gadolinium deposition, and the ECV is slowly returning to normal, showing you that the MR is a good tool to actually look at these patients. The myocardial T1 in amyloid also helps us to tell us that when we have a high T1, the survival curves go down, and when the ECV is high, again, the survival goes down, showing you they have a very good prognostic capability as well. Magnet and iron are like water and fire. They really complement each other. What is important is that you can have a patient with thalassemia with a high ferritin and a high iron, but no myocardial involvement, as in this picture with the blue arrow. but all the iron is in the liver with a good prognosis. And this is a patient with a similar ferritin value, but there is hardly any iron in the liver, but it is all there in the myocardium. And MR does a very good job using a tool called T2 star, which is a software, and you don't need to give contrast, so you can do it at a fairly cheap rate. Fabry's disease is always on the cards when you have a hypertrophied ventricle, when you've ruled out HCM, hypertensive heart disease, and aortic stenosis. The classic scar in the infralateral portion and the low T1 and the low ECV are classical features of Fabry's disease. We are all comfortable with this very dilated ventricle and dilated LA with a normal RV, but what is more important is the presence of gadolinium in this patient, and you can see that here the T1 values are marginally increased and the ECV has expanded, showing you that this is pathological. And what is important is that compared to a patient with no scar here and compared to a patient with scar on the MRI, completely mirrors the histopathology and correlates with a sudden cardiac death and a very low survival in these patients. PPCM is again a diagnosis that we get a lot of referrals for. They present just like dilated cardiomyopathies, but a good number of them have no scar and they do very well over time. ARVD is another disease which we have a lot of referrals from EP. The dilated ventricle, if you have an EF of less than 40 or an end diastolic volume more than 110, RV evaluation, I think MRI is the gold standard for it. If you can add on fat deposition here and scarring here, you really have a very good diagnosis of the disease, ARVD, and these patients get an ICD straight away. Hypertrophic cardiomyopathy, again, no points in guessing this on echo, but what is important is all the features, including the mitral regurgitation, the LVOT, the thickened septum, can be clearly seen and quantified. But the icing on the cake is this mid-myocardial, mid-septal scar, and the quantification of which gives you the number more than 15% is now a 2B informal indication for ICD. You can see the T1 values are marginally elevated. You can look at the scar here and you can see the widely expanded septum. And this is also a very important way of differentiating a hypertension heart, a hypertrophic cardiomyopathy, and an athlete's heart, which will have a normal T1 and ECV value. Again, preserved ejection fraction, EMF comes to mind, and you can clearly see the obliterated RV and LV apex. This is very important clue, and the arrow-shaped gadolinium enhancement on the LV and RV are real, extremely good clues to make the diagnosis. Lastly, ending off, this is a nice picture. I wonder if any of you would like to take a guess. I don't know if we have anything on the chat box. If you can use it, I will just keep it open for you. So cardiac MR is very good for characterization of masses, and this is the gadolinium enhancement. This will be the quiz, hopefully, for you. And if you can answer this. What is important also is we see these kind of masses in the LV, and this patient was sent to me for a mass evaluation. But what I did find is not only I found the mass, characterized it, including the mild obstruction of the mitral valve, but I also found the delayed enhancement along the anterior septum. And I also characterized this mass correctly as a thrombus based on the TI 600. And we did the angiogram. There was a totally occluded LAD, which caused an akinesia, and the scar in the LAD territory and the thrombus grew out of that akinetic or dyskinetic segment. So just to conclude, cardiac MRI is a very important tool in cardiovascular disease, both for ischemia, volumetry, for atrial, and more importantly, for the characterization of the large variety of cardiomyopathies that we see on clinical practice, both for the diagnosis, the prognosis, and also for the follow-up of these patients. Thank you very much, and happy to take a few questions.
Thank you.
Anybody would like to take a guess on that mass?
Very difficult, because most of us is not seen, but it looks like some multiple cystic structures were there.
It's a hydrated cyst. It's a hydrated cyst.
Okay.
What is important is it gives you the plane of enucleation. So it's very easy for the cardiac surgeon to go in because it's a very nice enucleated plane. It helps him make the decision for surgery.
Okay, so it was like because we are not very tuned in to see all these things, and it was like a more fairy tale structure journey, like giving an overview of what MR can do and what are the different things. And the best part was that slide which you showed, that how structurally first you give you get an idea about the kind of pathology, then you do a late gadolinium enhancement, then you do a T1, and then you do a ECV estimation. So this is great. From my side, I would just like to ask you that if you could please re-explain that what is the significance of each one, because many of the fellows, residents, and probably to quite an extent ourselves also, we are not very tuned to using these values like ECV and T1. So how do we interpret these things, and what are the clinical significance? What do these actually indicate?
Yeah. So as I said, the T1, we must remember that these are fairly recent advances, as you can imagine. These are restricted to a very few centers in the country. So these are not something which even routine imagers would be familiar with, but this is obviously the future. The T1 basically is the intrinsic relaxant property of the myocardium. So because the MR is very good at evaluating the proton alignments, the T1 is an intrinsic property of relaxation which the MR is able to capture. And a normal individual has a T1 anywhere between 975 to 995. But as I said, there's a lot of heterogeneity. So that is why the T1 map has to come from the local center. What I mean is that suppose I am doing T1 mapping at my center in Hyderabad with a Siemens machine. Those T1 maps are exclusive to that machine. So I would have had to do 100 or odd normal patients or patients without pathology and generate those T1 maps. So that becomes my T1 library. So my T1 library numbers may be different from what is happening at GB Pant. So that is why T1 mapping is a very sensitive kind of a parameter, and is very dependent on the local magnet and the local database that you have. And as you've seen, there is a bit of an overlap. So all these things cannot be taken in isolation, like all good things in cardiology. We all see in daily life. So it is important to checking.
Your voice is not coming, Johann.
Not again audible. Okay, I'll put off my video. Okay, so as I said, the T1 map is very specific to the magnet, and it is just one component of the overall assessment that we do. So we do not make a diagnosis just on T1. So that's something I want to re-emphasize, because there is a considerable overlap with those numbers. After all, they're just numbers and they're very fine. But as I said before, when you're looking at pathologies, for example, you're looking at a patient with hypertrophic cardiomyopathy versus a patient with athlete's heart versus a patient with hypertensive heart disease versus a patient with a mild aortic stenosis. So if you have an elevated T1 and also an elevated ECV, ECV, as I said, is a more objective parameter because it's a derived parameter. It looks at the T1 before gadolinium and the T1 after the gadolinium. So since it is a kind of a ratio, it is more objective and can be traded across centers in the country. So my ECV would be approximately similar to the ECV that you get, provided you've taken care in giving the right amount of contrast, waiting for that 10 minutes, and then repeating the T1. So if I have a patient on the septum with elevated T1 and an elevated ECV, clearly this is pathological hypertrophy of the septum. It's not an athlete's heart. It's not a hypertensive heart disease, but it is clearly a cardiomyopathy of some sort, most probably a hypertrophic cardiomyopathy, could also be Fabry's disease. So in the same patient, if I get an extremely low T1, that would be more of Fabry's disease. And if the T1s are elevated, it's the classical hypertrophic cardiomyopathy. So that's how it really helps us. And the ECV in Fabry's disease again is low. So the similar thing in amyloidosis, if you find a restrictive physiology in a patient, if you have a very high ECV and a high T1, you don't need to do a biopsy of the septum to prove it's amyloidosis. It's there and standing in front of you. And these patients can be treated literally without doing a biopsy. Was that clear?
Yeah. And as far as the assessment of the valvular lesions is concerned, especially when we talk about mitral stenosis with rheumatic heart disease being so common. So like in echo, we have a very typical Wilkins score. So have we tried to devise any particular score for assessment of mitral valve disease to show that actually, rather than just showing you emphatic images, MR is really contributing to the decisions whether these patients need to be intervened by percutaneous treatment or by surgical management of the valves?
Yeah, so the short answer to that is MR is no challenger to echo, especially definitely not to T, but it just adds a supportive role in being a second or third umpire whenever there is those doubts. Also to look at atrial structures in patients with borderline mitral stenosis. You want to look at the left atrial volume. You want to look at the left atrial appendage, for example. MR really shines there, but it is truly just in a supporting role and really no competition to a very robust Wilkins score that we all have on the echo. It really
it
shines.
Please go ahead.
Please continue, Johann, please.
Yes, Sumud, you were asking something. Please go ahead.
Okay. No, it was very beautiful lecture. Some technical doubts, like most common consideration that we can listen, patients on devices, patients on coronary stents, patients on pacemakers undergoing MRI. So we all feel that nitinol is safe. So what is the how should you address those questions?
So here it is a conditional kind of a assessment wherein, as you know, that most of the MRs today are MR compatible. So we take in these patients provided they are in the VO mode. We have the EP person and the company person coming and programming them. The magnet has to have a special software wherein you're able to do what is called a banding because the pacemakers and ICDs cause terrible artifacts in and around the heart. So without the banding software, unless you're looking at something very specific like a follow-up in a sarcoid patient, for example, that's the commonest we use it for, the images are really bad. So that's where, post devices, we look at the PET scan. So we do a baseline MR in these patients, especially I'm talking about the inflammatory cardiomyopathies. We do a baseline MR, we do a baseline PET, we put in the device for these patients, and then the follow-up every year is generally done by PET alone. Because MR, especially cardiac, it's very, very challenging even with an experienced operator to really, use the software and get around these kind of artifacts. They're huge artifacts. So I would believe there's just a couple of us who would actually do MRs in these conditions. You can do MRs for any other indication, obviously, head and abdomen and whatever.
What about stents? If the patient has had a stent, they will ask whether I can go for an MRI or not.
Generally, with the new generation, 4 weeks is all we require. And after 4 weeks, we image them fairly comfortably.
Okay.
Same with the nitinol devices, atrial as AST device, and those devices also nitinol devices. 4 weeks
Yeah,
we
so you will
generally.
get, you will get a large artifact in the area around the device, but the other structures of the heart can be fairly comfortably evaluated if that is what you want to see. Otherwise, we just get around to doing good cardiac CTs nowadays. We get around to looking at morphology now in such situations.
So there's a question from Dr. Sanjay Tyagi from Delhi. How common is Fabry's disease in your clinical practice you have seen?
It's fairly uncommon, sir. It's actually rare, but we do get these sporadic cases because we are a referral lab, so we get a lot of these hypertrophies. There's clinical suspicion, and then the MR helps us out. We obviously do the enzyme test after that, which confirms the disease. But MRI definitely gives us a fairly big clue that we are sitting with a possible Fabry's disease. And with the new T1 mapping, it's become a little easier as well. But it is a rare disease, no doubt.
Especially in setting of sarcoid, what should be the best option? Should PET CT versus PET MRI should be advised? Which will be a better modality or equal?
Yeah, as I said, PET MR is already available in about, I believe, 4 centers in India as of now, as far as my knowledge goes, in Delhi and in also in Cochin and also Mumbai. So one cardiac indication in which PET MR really shines. I mean, if you have a volume of that and your business guy says, sir, shall I get a PET MR? It is sarcoid. Sarcoid is the disease in cardiology wherein the PET MR will truly keep your business development guys happy, because it is a classic disease which has a varying composition of inflammation and scar in different proportions. And the PET does a great job for inflammatory evaluation by the FDG, and the MR does a great job in scar evaluation. So your turnaround time is very fast. You get it done at the same center. So the PET MR is an extremely great tool for not sarcoid, but all inflammatory myocarditis conditions, including TB, sarcoid, myocarditis, so on and so forth. So we send our patients to a PET scanner away. So these patients have heart failure, they have recurrent VT, they're fairly sick. So a PET MR can really clearly take away the logistical jam which is there very easily.
Yeah.
But its role in cardiology is fairly limited for various reasons.
Yeah, Dr. Rohit from Bangalore wanted to ask, in hemochromatosis, what do we see in T2 star image?
Yeah, so what we do see is we use the T2 star. It is a kind of a tool we use before gadolinium. That's very important when you're sitting with your tech. Do not give gadolinium before you do the T2 star imaging. And the T2 star images have a low T2. So we have a software which is a downloadable Google-based software that we use, and we map the myocardium using the T2 star sequence. It takes exactly just about a minute. From base to apex, we map based on the T2 echoes. And then we map it. In fact, it was there in the picture. We map it out, and the lower the T2 star values, the higher the iron content. So based on the software, we can tell this has been obviously developed by Dr. Pennell, who is the pioneer of the T2 star technique and hematochromosis. He's done a lot of work in Sicily, in the south of Italy, using a mobile MR scanner. And based on that data and now other data from elsewhere, the lower the T2 star values, the higher the iron levels. And as I said before, it allows us to go in for more radical intravenous based desferoxamine compared to the oral chelation therapy, and also obviates the need to do repeated liver biopsies like most of us have been doing in our residency time in MD medicine. We used to keep doing liver biopsies because we truly know that the liver is not the a house of iron all the time. The actual house is in the heart, And the presence of iron in the heart is a very sinister prognostic indicator compared to iron in the liver. And both will have exactly the same ferritin levels. So the cardiac MR with T2 star really helps in the diagnosis, prognosis, and also helps in the chelation therapy. Because it does not involve contrast, it can be done in 5 minutes. I do it in 5 minutes. So a lot of the patients who are socially disadvantaged, I do a lot of MRIs at a very nominal cost, and we get a very good index of the iron levels in their heart and help them through the Thalassemia Society of India, whom we have a good partnership for the last decade.
Dr. Johann, you also told that because the smaller centers may not use the appropriate protocols, and you may miss out on many, like sarcoid and all can be missed out. So how can we overcome this? We need to specify some things as we request them, or?
Yes, I think what is important as the treating physician, the referral physician, we need to have a chat with the imaging person. That's very important before you send a patient. In fact, I would say that is crucial because the machine does the job anyway, as you've seen, without much of individual variation. So you need to be very clear upfront what you're looking for, what is the disease you're suspecting, what are the other differentials that could be, and only then you're going to get a very reasonable and good assessment. Otherwise, you're going to get a lot of junk, and believe me, it can just take you in a completely different tangent. Same MR, same person, same patient. We do see all these at the fag end when they come for the tertiary and quaternary referrals. Diseases like sarcoid especially have been missed completely.
Okay. Any other? Yes, Dr. Grish, any questions, any comments from your side?
A nice lecture, a nice talk, Johan. I just want to know, in your practice, what is the incidence of tubercular myocarditis in patients who have been evaluated for the etiology of dilated cardiomyopathy?
Dilated cardiomyopathy?
Yeah, tubercular.
Yeah. So we have a fairly ongoing case series of almost about 150 cases of what we call inflammatory cardiomyopathies, which present both as restrictive, dilated, with a little bit of hypertrophy also. We have almost 150 cases ongoing. We published some of our work. And we use a combination of MR, PET scan, and very guided mediastinal lymph node biopsies to get the diagnosis. And we have had situations where only the culture, which comes after 12 weeks of the biopsy, clearly discriminates between sarcoid and TB. So we have a whole wide variation of tuberculosarcoid or sarcoid or tubercular diseases. And some of them we just give both therapies because it becomes very difficult, except for the culture. Their patterns we have analyzed, the scarring, the mediastinal nodes, they're almost identical.
What is the response to anti-tubercular drugs in such patients?
If they are proven TB on culture, they do extremely well, provided the scar burden is not being extensive from the beginning. Once the scar burden crosses about 50% or in that region, irrespective of what you do, their incidence of sudden cardiac death, VT, is very high. But if you catch them in the inflammatory stage, and that is why the PET-MR is so good in this, they do extremely well if they have a predominance of inflammation and less of scar. Once they go into the scar phase, irrespective of what you do, they succumb. So here only ICDs help them to some extent. But when they have the mild inflammation ongoing, even the ICDs don't help.
Okay. Thank you so much, Dr. Johann. It was a great lecture, a very, very nicely illustrated images explaining, and at least it was very thought-provoking personally for me, and also I believe for almost all of us, more than 200 of us joining on live on YouTube as well as Zoom platform. It was great, and I would strongly recommend that everyone should go and read this MRI imaging in cardiovascular diseases. There are numerous chapters and articles that have been published, and it would be a great idea to refresh your knowledge and revisit, not only from the point of view of exam, but also from our clinical perspective, because it has given us a new direction and a new thought process today. And we'll be continuing our journey on imaging next week. We'll be talking about CT scan, the role of CT scan in cardiac diseases, and the nuclear cardiology that has always had tantrums, which test to use, when to use that particular test, what is the right interpretation of the images. So we'll go step by step to make all of us understand that this is the way and this is a test to be used in this particular condition. And Dr. Johann, we are really looking forward to your next talk on next Thursday. And thank you, my colleagues, Dr. Sumo, Dr. Grish, and everyone who has joined us today. And thank you, Intas, for providing us this platform. If you have any questions, comments, and clarifications, please let us know. We will also take up the answers to the questions that Dr. Johann had shown today. Probably we just missed them out, and we'll start with that, recapitulating those important take-home messages next time. Thank you for joining us. We'll see you next Thursday, same time, with part 2 of the series of Basics in Cardiac Imaging. Goodbye from CSI.